I'm an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf and this episode is everything you need to know about weight gain, obesity, menopause, sexual health, all that great stuff. But of course, before we get into it, this is not meant to be any type of medical advice. If you have any questions about your health, make sure you go see your healthcare provider. And if you have any questions about your religion, make sure you go see your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super excited to welcome on to the podcast my friend, Dr. Sarah Stombaugh. Dr. Stombaugh, if you could please introduce yourself to all the viewers and listeners and guests out there.
Yes, absolutely. Well, thank you so much for having me today. I'm really excited to connect with your audience. My background is in family medicine. I did additional training in obesity medicine, and I now have a private medical weight loss practice in Charlottesville, Virginia. I love talking about the role of how our weight affects so many aspects of our life, including sex. And so I'm excited for us to talk about that today. And yeah, really share with your audience the role in which weight can have, both from a positive and from a negative standpoint, even during both having obesity as well as the weight loss journey.
Yeah, I bet you haven't talked to too many people about sex and obesity before.
You'd be surprised in my clinic a lot, but not necessarily on social media or in any sort of broader context. It'll be fun to share that.
Oh, amazing. Well, this is fantastic. So, how did you become interested in obesity and women's health?
It's definitely been something I've been interested in for a long time. I've always really loved the idea as food as medicine. When I decided to go to medical school, it was actually a very big passion of mine to learn how to support people with food, understanding their bodies. I grew up in a really rural community in Illinois where many people, including many of my family members, really struggled with weight, and it never really made sense to me why people living in the same community with the same access to things, why some people had problems with their weight, felt like they really struggled with obesity where others didn't. So it's actually a big part of why I chose primary care. And it's actually a little disappointing how little education I got in that, both during medical school, but then even through my family medicine residency. And so I really intentionally carved out time to be able to work with other people in this space, in the obesity medicine space, when I was in residency, trained with some of the docs in University of Chicago and around the Chicago region, which was really fun, and started implementing that into my practice. I think as a female physician, also working with women patients, there's so much when we think about our health beyond just, I know what I should eat or know what I, should move my body. And so really reconnecting with our mental health, with the behavior changes that we make and how that applies to our overall health, to our metabolic health, but across other areas as well.
So good. So, you work with many women in midlife. What have you noticed about weight, hormones, metabolism as they start to shift during this stage?
Absolutely. So it's a time a lot of people reach out to me where someone, particularly if they haven't really struggled with their weight beforehand, they feel like they have this good routine of I sort of know my body, I'm eating in a certain way, I'm moving my body in a certain way, I have the same sort of day-to-day routine, and then all of a sudden they're doing the exact same routine and they find that they're gaining weight, feel like sort of out of nowhere. And so that's a time where certainly people may reach out to me and ask for support because they feel like I'm doing all of the right things and they're not working anymore. And we know that there's a lot of shifts that happen with our body during the perimenopausal and postmenopausal years that can really contribute to changes in certainly our overall health, but our weight as well.
Yeah, 100%. That's actually one of the biggest things that women come to me for, right? Is they are in perimenopause or they're in menopause and they've been struggling with all the hot flashes, the night sweats, and the brain fog and all that stuff. But then one of the most distressing things is the weight gain. And, they just can't get it off. They don't even, they don't understand. And even when they are placed on hormones, and I'm sure you and I will probably talk about this, but even when they're placed on hormones, there's a little bit of where that needle will move a little bit, and they'll lose a little bit of weight, but still is not to where they want it to be. And so then a lot of women will ask about the GLP-1s and weight loss medications, but we'll wait till we get to that question in a little bit. So, how do you define obesity as a disease rather than just on the scale? And why is this distinction so important, especially for menopausal women?
I think this is really important because we're thinking about obesity as part of the metabolic disease spectrum. So, when I say metabolic disease, I'm thinking about all of these things that are correlated together with increased body weight, particularly central body weight. We'll see things like elevated blood sugar, elevated cholesterol, elevated blood pressure. When you're looking at waist circumference, you'll see increases there. And all of this is correlated with each other, and a lot of it is driven by underlying hormonal change. And sometimes we say hormonal change, meaning the sex hormones. So things, I said that funny, but things like the sex hormones, like estrogen, progesterone, testosterone. But honestly, even insulin, for example, is a hormone and one of the most important hormones in our body in terms of signaling how we use and store our energy. We know that there's a lot of changes that can happen, honestly, at different stages of life. But even as we think about the peri or postmenopausal woman with declining estrogen levels, we see this increase in insulin, an increase in insulin resistance. And so we start seeing these underlying hormonal changes that happen. And it could be this really like self-perpetuating cycle whereby when we have the early signs of insulin resistance, it drives increased cravings for sugar, for flour. We know that fat mass on our body is very hormonally active. So sometimes we think of fat tissue as this blob sitting on our body, but fat tissue is actually very, yeah, right? It's like actually very hormonally active. And so it further drives insulin resistance, it drives leptin resistance. So leptin is one of our main satiety hormones. So when we end a meal that we feel full, we feel satiated. And so with leptin resistance, we are experiencing, we're eating, but we're not getting full as quickly. So people are having these effects of increased insulin, increased leptin, resistance to both of those things. So they're both feeling hungry and cravings more often. They're not getting full as rapidly. And you can imagine how those would contribute to the weight changes. And so the challenge is that even if we're listening to our bodies or we're trying to eat in a certain way, we feel like we're sort of fighting our biology, and we are. And so if you're trying to calorie restrict, you're trying to eat less food, eat less often, maybe leaning towards certain macro choices, it could be really challenging where you have these underlying hormonal changes that are not really allowing those things to take effect in the way that we want them to. And so when we think about treating someone's obesity, supporting their metabolic health, addressing those underlying things, whether it is with a GLP medication, for example, there's other things we can do too beyond that, but addressing that underlying metabolic health as well as then all of the other pieces is important. So it's not really an either or, it's a both and with these pieces.
Well, tell me a little bit about this. So, what actually happens to a woman's metabolism and body composition during the transition to menopause?
I think the body composition is the piece that I will really focus on when I'm sharing and talking to others about this, and that there's a lot of changes that happen as a result, particularly of some of those declining estrogen levels. So we see this increase in insulin resistance. So that will drive increased fat storage, particularly that visceral adiposity. So that weight gain centrally in our body, on the abdomen, the softness that many women will experience around their central body. And so there's this related
I
to
like
the
you said
insulin resistance.
softness.
Yeah.
The softness, like, I
Yeah.
think of that as just like my little love handle,
Mhm.
but I like that's a nice
Yeah.
euphemism,
A
the little softness.
gentle, yeah, a
Yeah,
gentle way to describe,
yeah.
a part of their body that a lot of women really feel frustrated by, right? Because it's not something that's always necessarily been there and feel like it's a little bit out of their control. And so you have this piece, and then you're also thinking about So you're storing more fat, and then as we're getting older, and this is actually more age related than sex hormone, like estrogen related, but as we're getting older, there's a decline in our muscle mass as well. And so this natural decrease in muscle mass, and this happens for men and for women, starts accelerating during the perimenopausal years, continues through later in life. And so you have the situation where you're both storing more fat, you are losing muscle. And when you are trying to put on muscle, it can be a little bit more challenging to do that. And those two things together create the situation where even if our weight is the same, we may have a different body composition. So a little bit higher fat mass, a little bit lower muscle mass. So that contributes to some of that softness that I was describing, as well as then when we think about metabolic rate, the way in which our body uses energy now looks different because of a different body composition. So, if we think about how much energy it takes to keep a fat cell alive versus a muscle cell, our bodies burn a lot more energy with muscle compared to fat mass. So, as we're losing muscle mass and this ratio is shifting, our metabolism starts slowing down as well. There may be other changes that are happening in that stage in life. Children are getting older, sometimes retirement is happening. So there could be other things too that sort of muddy the picture, and we start to see overall there's more fat mass, there's less muscle mass, there's a decrease in metabolic rate as a result of all of that. And it all feels like it's happening at once, which can be super frustrating.
Yeah. Yeah, a lot of stuff happens all at once. Absolutely. So tell me a little bit about the estrogen and progesterone effect and how they affect fat distribution, insulin sensitivity, and muscle mass.
So, a lot of this, we know that declining levels of estrogen in particular can really be related to our metabolic health. And so, as we were speaking about a little bit earlier as well, those lower levels of estrogen start contributing to insulin resistance. So, we start seeing where people are shifting, having more hunger, having more cravings for certain type of foods. The way we store our weight looks a little bit different with that weight storage in the middle. And so, certainly, the hormonal shifts that are happening during peri and postmenopausal years can really contribute to increased risk of metabolic disease, including weight gain, prediabetes, diabetes. And so many women will see this. If they look at their beyond the number in the scale, beyond the what they see in the mirror, the way their clothes are fitting, even on certain labs, we start to see these early changes with like blood sugar, for example, that
Wow.
there's this reference range of what we consider normal. Usually 60 to 100 or 99 will be considered normal. And then anything 100 or higher will flag as abnormal. And women might start seeing these, 102. They might start seeing these upper 90s. So it's like 99, 98. And they see over years that their fasting blood sugar numbers are creeping up. And so there's other signs that are happening sort of subtly alongside of it, all pointing to that change in with declining estrogen levels, this increase of insulin resistance, and that sort of cyclical thing that can happen.
Yeah, I mean, it's, so many women struggle with this, and we see it, right? As the estrogen gets lower, and as women go into postmenopause, their insulin just is not working as well, right? So they have decreased insulin sensitivity, so they start to become diabetic. And we know from even just the WHI study, we know that estrogen helps to decrease that risk of getting diabetes, right? We know that if women start estrogen, it really helps to sensitize that insulin. So to help prevent with some of that, pre-diabetes and diabetes, absolutely, that you're talking about, that metabolic syndrome that starts to happen. A lot of women say, I'm doing what I've always done, but now I can't lose the weight. And I hear this all the time. So I think you mentioned a little bit already what's really happening physiologically.
Exactly. We have basically our hormones start fighting against us. And so there's other, while there may be changes in our life, even if there aren't, we've got all of a sudden this major shift in our physiology with declining estrogen levels, declining testosterone too, which we haven't really talked about too much. That can contribute to, so we've got this decrease in estrogen that can cause insulin resistance, less insulin sensitivity. So we're gaining that visceral adiposity, declining testosterone levels in women, and I know you talk about this in the podcast and other contexts as well, but I think a lot of people think as estrogen and progesterone as women hormones and testosterone as man's hormone, but we know that testosterone levels are also declining in women as they're in their peri and postmenopausal years. And so that can also contribute to things like changes in energy level, decreased ability to put on muscle mass. So there's all these changes working together sort of against us.
Yeah, absolutely. And it's so hard to put on that muscle mass, right? To increase that muscle. So, how does the abdominal or visceral fat in menopause impact overall health? And I think you were talking about that, particularly the cardiometabolic and sexual health.
When we think of this, the term cardiometabolic has really gotten trendy, I think, in the last couple of years. But what we've learned is that all of these things are related together to one another. And so when we look at weight gain that happens in our central region, sometimes we think about weight gain being on the outside of our body, but it also happens on the inside of our body. So visceral adiposity in particular, this is weight gain that's happening in and around our organs, can have really big impacts on our health. And so we see this increased risk of heart disease, for example, increased risk of other health conditions as well, but particularly that increased risk of vascular disease, of heart disease. Those are very closely tied to this visceral adiposity that can happen.
Yeah, so that really makes a huge difference, right? When we focus on that and try to decrease that visceral fat, because we know it absolutely impacts our heart health, especially. So, how does obesity affect sexual function, both hormonally and physiologically?
Mhm. This, in so many ways, our obesity can affect sexual health. There's everything from what is happening from a hormonal standpoint. So, both having obesity and having increased fat mass on our body can affect our hormone levels. You know, for women, we may see changes where there are increased levels of estrogen, and this particularly for young women who are thinking about polycystic ovarian syndrome, for example. We see changes in a hormone called the sex hormone binding globulin, and this elevated protein level that can happen, or decreased protein level that can happen, even like in a PCOS patient, for example, can create an imbalance of our estrogen to testosterone ratios. And we see all of these things then impacting the way that our bodies are functioning sexually as well. Certainly, as we look at what is happening going through the peri and postmenopausal transition, those declining levels of hormones can affect us, but we'll also see changes, sometimes increase, sometimes decrease, depending on which health condition we're talking about, changes in how much active sex hormone that we have. So we can see people struggling with having less active sex hormone related to that fat mass that's on their body. We also know that even losing weight, in some ways, it, of course, is a good thing, and can be helpful in a lot of different arenas of health. But we know that rapid weight loss, for example, and unsustainable or rapid malnutrition can actually create a situation where sexual health plummets. And so while obesity can contribute to negative sexual health, rapid weight loss and unhealthy weight loss can as well. Certainly having less fat in our diet can decrease the production of some of the sex hormones like estrogen and testosterone. So some people will feel, you hear people talk about fatigue, this lack of energy that can come up on a GLP or after bariatric surgery or weight loss for any reason. And we know that that can contribute to declining levels of these hormones. So people are also feeling a lot of times a really decreased amount of libido as well. And so there's both this how we're addressing and supporting obesity so that we're able to improve sexual health. But then when we're doing that, we want to do that in a way that's very sustainable, that's emphasizing different macronutrients that are going to help support our body's overall function, thinking about things like protein for muscle mass, thinking about fiber for, gut and GI health, thinking about fat. Fat is not bad. Having fat in our diet plays a really important role in brain health and some of these hormone productions. So you really want to be mindful too during the active weight loss journey that you're addressing these things so that you don't decrease libido and have challenges in a different way. I think too, there's really big psychological impacts of our relationship with our body. We think about the safety that we feel with our partners, and having sex is such a vulnerable thing to do. And when you're with a partner, you're naked, you're very exposed. And so that relationship that you have with your own body, the relationship with your sexual partner that you feel comfortable sharing, and your body changing and sharing that with someone, because mechanically there could be challenges with having obesity and having excess fat on our body that can make sex challenging. But as we see weight loss happening as well, our bodies start changing in different ways. And we think of it from a positive way, but sometimes there's even changes where someone, for example, has a significant amount of weight loss and may have loose skin, they have excess skin. And so there can be new confidence issues that can come up. And how are we addressing that? And do we feel safe in our sexual environment?
Yeah, that's a very good point. So much of our sexual identity is tied to our body image, right? How we see ourselves. And you're absolutely right. When that starts to change, right? How is it that we feel about ourselves? Some people feel more confident. Other people are just, they have imposter syndrome, right? They don't feel like that it's really their body. And so it's really interesting to see how that affects. There's been some talk about like GLP-1s and libido and maybe not, finding pleasure because the GLP-1s act at the level of the brain, right? And so sometimes they can decrease the dopamine. Is that right? And you'll tell me that. So, I'm wondering how that affects sexual pleasure. Any thoughts on that?
Yeah. That's a great question. I think when we look at the effect of GLP, a lot of people think about them, how they're happening in the GI system. So we think about them from a weight loss perspective in that way, but they're quite centrally acting as well, as you mentioned. And so part of when you look at it from a weight loss mechanism, part of how they are supporting the brain and the body is that there's this decreased hunger. And when we think about hunger, there's physiological hunger and there's psychological hunger. And those two things go really closely hand in hand with one another. In that, if you're experiencing physiological hunger and then you turn and look at your refrigerator and you're like, okay, what sounds good right now? That is tipping over into that psychological hunger category. And that dopaminergic system, this psychological hunger, translates to a lot of other things as well. So, cravings, urge, desire, libido, it's all part of the same pathway. And so I do think it's really important when we're looking at GLP therapy that we're thinking about how this can extend to other health conditions as well. Certainly there's a lot of data emerging on this in the treatment of certain substance use disorders. I have a lot of patients for whom, in taking this medication, they find they have a lot less craving for alcohol, but it can tip over into this like almost anhedonic feeling where patients are not getting the same pleasure from certain things. And there can be a little bit of maybe apathy. So I do think it's really important to pay attention to how you're feeling on these medications. There's been some post-marketing reports of increased levels of depression with these medications. Interestingly, because they are essentially acting. So it came up in post-marketing reports of Ozempic, which is one of the semaglutide products. And because these medications are working in the brain, because they are affecting these neurotransmitters that are so closely related to mood, we really want to think about how that it could extend to other areas. So I would encourage any of your listeners who are taking these medications, or if they're thinking about taking these medications, to pay attention to, not just hunger, not just weight loss, but how it's impacting other areas of their life as well. And sometimes if you're starting to tip over into that like apathy, anhedonia, like I just don't really care territory, that may
Yeah.
be a sign that you are overtreated with medication and that a
Mhm.
smaller dose may be more effective for you.
Yeah.
But certainly it's just a good thing to pay attention to. And if you're noticing that come up, bringing it up with your prescribing physician, because it absolutely could be related and could be a potential negative consequence, although it's certainly not one I see frequently.
Yeah. That's a good point. So, how much of sexual dysfunction in midlife is due to hormonal shifts versus, let's say, vascular or metabolic causes tied to obesity?
Oh, that's such a good question. I wish I could quote an exact, what is the percentage coming from this and that? And I think it's really muddy. I think all of these things interplay with one another in we're thinking about the way our body feels, the way our body functions for us. We know that, vascular health, for example, and we think of, even what happens with erectile dysfunction, for example, people who have obesity are at a higher risk of erectile dysfunction. We know that losing weight may help with that. And so there's all of these crossovers. And so as we're thinking about the role of obesity, this is where even going back to it as a sort of willpower disease versus part of our overall health, it crosses over into everything. And so, as we're thinking about supporting our health, whether it's our sexual health, our medical health, our mental health, all of these things really should be part of a plan together. And so, I don't know that I have a super clear answer for you, just that we need to be thinking about sexual health as part of all of this, and that addressing all of them together will be really important.
Yeah, I think you're absolutely right. And, to your point about sexual dysfunction and erectile dysfunction, we know that, one of the first signs of cardiac disease, right, are individuals that are not able to have an erection. And so, if somebody's having erectile dysfunction, they should really go and have an evaluation as well with their cardiologist to make sure that there's nothing else, right, going on, or that the arteries that supply the heart are not affected. Specifically talking about sexual dysfunction in midlife, you were talking about statistics. And so I know that I think it's actually from this one study called the Preside study, that about 25% of women experience some type of sexual dysfunction in midlife. In midlife, they define it as like ages 45 to 65. And 12% of those individuals have their sexual dysfunction is decreased libido. So I wonder that, those women that are suffering already from decreased libido, if they go on these GLP-1s, I wonder if they're, that might be a research question later on for somebody, right? Is that if they already have decreased libido, if they go on these GLP-1s, does their libido get worse? So that would be something really interesting to kind of look up. So I think you were talking a little bit about this, but what role does body image and self-perception play in sexual health for women struggling with weight gain?
Mhm. I think this is so important in sexual health, right? And we think about feeling safe and our own pleasure. Those things are very closely tied to one another, and our body image is part of that. And body image, interestingly, is not always directly correlated with our weight. I think a lot of times when a woman has been struggling with her weight for a while, there's this idea perhaps in her head that, okay, if I just weighed 120 pounds, I would feel better about myself. And the interesting thing is that's actually rarely true. And so as we're thinking about the weight loss journey, we really want to be thinking about that behavioral and psychological piece as well, because there's so much about learning to reconnect with our body, learning to celebrate our body, to appreciate and love our body that is not as correlated to our weight as we think that it is. And so it's really powerful to learn to love and to appreciate and to reconnect with your body. And you can still, from that place, lose weight and be working towards a weight loss goal. But I do think a lot of people assume that those things will be connected and that weight loss is just the answer. And it's actually rarely the answer in the way that people think it will be.
Mm. Oh, that's such a good point. And you're absolutely right. It goes beyond just the number on the scale. And actually, I want to make a correction. So in the Preside study, they found 44.2% of women had sexual dysfunction, and 12% of that was experienced from distress of a sexual problem. So actually, and the most common is low desire. So it's actually more than what I stated. I stated it was 25%. It's actually 44.2% experience sexual dysfunction in midlife. So that's an important correction. I think you're 100% right, right? Like body image is not just about, what we see on the outside, but it's really how we just feel about our bodies and, how we feel in them. So I know a lot of people that, in bigger body types that are very happy and have a very good, body image. So you're absolutely right. So let's get into the GLP-1s a little bit. I know people are really interested in that, and the GLP-1 receptor agonists like semaglutide and tirzepatide. How do they actually work in the body?
Yeah, absolutely. So the GLP medications have been around for a while, about 20 years at this point, coming up on a little more. And they were
You never
initially
know. I
approved.
never heard of about them before. It seems like they're
Yeah. I
taken
know,
off.
isn't it wild? And so in 2005, Byetta, the very first GLP receptor agonist, was approved for the treatment of type 2 diabetes. It was in the early 2010s then that they started more officially being studied for the treatment of obesity. And the very first one came on the market, Saxenda, which is a once a day GLP medication. It's a liraglutide medication. But it wasn't until the last couple of years that these medications have really popularized. And that's because they have once a week versions now. So Ozempic, Wegovy, Zepbound, Mounjaro, these are the names you're hearing all the time. Ozempic and Wegovy are the same as one another. Those are both semaglutide medications. Zepbound and Mounjaro are also the same as one another. Those are both tirzepatide medications. And then these all fall into the category of GLP receptor agonist. Now, interestingly, the tirzepatide medications, Zepbound and Mounjaro, are actually a dual receptor agonist. So it's targeting a second receptor also called GIP. But
Mm.
overall, the predominant effect that we're looking at is the GLP effect in these medications. And we know that GLP acts in receptors throughout our body. So they're predominantly located in the brain and in the gastrointestinal system. We see effects, for example, like delayed gastric emptying, a slower GI transit time. And this can help that food that you eat will stick with you for longer. So people may feel that they get full more quickly, that food, they may be hungry less often because they eat a meal and they feel full for a longer period of time. It can contribute to some of the side effects from these medications. So, constipation, nausea, these are common side effects that can be related to that slower GI transit time. There's also a change in when we do eat, what our insulin release afterwards looks like. And so, there's an insulin or a meal dependent, rather, insulin release that can be increased. So, it helps with energy storage after we've consumed a meal. We talked about some of the central acting effects. So, the way that it works in our brain, there's a decrease in appetite. And we can find that a lot of times too in this pleasure center, as we were talking about before, where there's a decrease of cravings and some of that over desire for food. And so it's really working on some of these underlying insulin resistant mechanisms, helping to support such that our body is less hungry, it's getting full more quickly, and can be really helpful, especially with those cravings, in helping to support you in choosing foods that are more in line with your goals because you're not having that over hunger or over desire for some of those other foods that are less in line with your goals.
So, do they have metabolic and hormonal effects that are relevant to menopause? I know that there's so many actually good things, right, about semaglutide and tirzepatide that help with heart health.
Yes, absolutely. So these medications have been studied in cardiac disease. And what's really interesting is that it's postulated that it might actually be the GLP molecule itself that's creating some of this improvement. When you look at the semaglutide studies, where they're looking at Wegovy in patients with cardiovascular disease and looking at outcomes once they've started medication, you see, like right from the very beginning, if you look at risk of heart attack, all cause mortality, the curves are separating from like week 3 or 4. And so these curves start to separate really quickly, even before patients have achieved a clinically significant weight loss. And so
Wow.
it's believed that it's the GLP receptor and in agonizing that specifically that may be creating some of these effects. So that in and of itself is really cool. A lot of going ongoing data there. But when we look at the hormonal changes that are happening for the menopausal woman, looking at decline in estrogen levels, having more insulin resistance, decreased insulin sensitivity, these medications are actually working exactly on that pathway, such that a woman may find that she's able to be more in line with her goals, maybe eat and move and just feel more similarly than she did when she was premenopausal, back before she was, she was doing all the things that was working well for her, going back to feeling that way. A lot of women will describe that using these medications can help them feel sort of like themselves again.
That's so interesting, right? And so, yeah, that was my next question, but I think you already answered it, right? That how the GLP-1s influence insulin resistance and inflammation and heart health.
Mhm.
Yeah. So, what do we know about GLP-1 use in women on hormone therapy? Are there, synergistic effects? And I think you and I were talking a little bit about that before.
Mhm. There are actually, and there's some clinical trials, smaller trials out of small academic centers, or I shouldn't say small academic centers, but out of academic centers where they've looked at what is the effect for women who are taking estrogen replacement therapy alone or estrogen progesterone hormone replacement therapy with or without GLP therapy, and women who are taking GLP plus or minus estrogen therapy and progesterone therapy. And what has been really interesting is that we know that for women who take both of those things, that they have more improvement in their metabolic health compared to women who are doing that alone. And so layering on these two things together can be really supportive of some of the changes that are happening sort of in both, basically two different directions. We're approaching the same thing. And so the combination of menopausal hormonal therapy with estrogen and or progesterone if it's needed for a woman who still has a uterus, and then layering on the GLP, these are absolutely synergistically effective. And patients will describe that. They'll feel a difference when these medications are layered on top of one another. And it's really powerful to see the change in women.
Yeah, I was just at that Menopause Society meeting in October, and they were talking about this, and they were talking about the synergistic effects, and they were saying how, when women are on menopausal hormonal therapy and a GLP-1, they tend to lose more weight than
Mhm.
just doing menopausal hormonal therapy by itself. So that's really,
Absolutely.
yeah.
Mhm.
So beyond weight loss, are you seeing improvements in energy and mood or sexual function among your menopausal patients using GLP-1s?
It's interesting. I am also a menopause certified provider. And so I'm often talking to patients about these different pieces and layering on estrogen and progesterone, sometimes testosterone. And so it's not always easy to tease out which effect is coming from which medication. But certainly when we look at the effect of these medications, we know that a lot of people just feel they have less of that food noise. Their brain feels cleaner, their life feels a little bit easier. They're able to stick in line with their goals. So the mental health aspect of that can be really significant. We also then see changes where there's decreased inflammation that happens with these medications. So we haven't talked too much about this, but these medications are being studied also in certain inflammatory health conditions. We know that conditions like asthma, like irritable or rather inflammatory bowel disease like ulcerative colitis and Crohn's, certain inflammatory arthritis conditions, things like rheumatoid arthritis, psoriatic arthritis, and certainly other autoimmune diseases as well. We're seeing this improvement in inflammation effect. And so a lot of people are noticing that in taking these medications, they may feel more energy, they may feel better. I do think it's really important to point out, as we were talking about a little bit earlier, that fatigue that can come up during the weight loss journey as well. And this is where I really work closely with my patients to make sure that they have a slow weight loss. Major air quotes there because it doesn't necessarily have to be actually slow. People be talking about 1 to 2 pounds per week on average, but some people are really excited to get the weight off. They want to titrate up to a higher dose of their GLP medication. They're excited to lose weight rapidly, but actually losing weight at a slower rate can do a few things in terms of protecting body composition. So we're able to still maintain our muscle mass during our weight loss journey. It could be really important in terms of metabolic, like our daily metabolism and how much energy our body is using, making sure we're eating enough food to fuel our body, because that plays a really big difference in fatigue, in energy, that can translate to other things like our desire to exercise, our desire for sex. So it translates across other things as well. So while I do think there's this improved inflammatory effect and people may be feeling better from that standpoint, we do want to be judicious with how we're using the medications, how rapidly we're losing weight so that we don't tip over to a place where we're having, run down energy levels, feeling fatigued, not having that same desire for sex.
Hmm. Yeah, such a good point. I'm just curious to know what you think about microdosing, and I know this happens all the time, and a lot of women are doing microdosing.
Mhm.
What are your thoughts on that?
I think microdosing can be a phenomenal tool. It's interesting because there's a handful of different definitions of microdosing. Some of it can be taking a lower dose than is even commercially available of medication. Sometimes it can mean taking a lower dose than is approved for long-term treatment. So maybe the starting dose of medication for a long time. Sometimes it means taking an intermediate dose of medication. So let's say you're going from a 0.25 of Ozempic to a zero point 0.5 of Ozempic. Are you taking some sort of intermediate dose of that, for example? So it can mean a lot of different things. The data on microdosing in terms of inflammatory health conditions. There's starting to be some emerging data on that. A lot of it at this time is fairly anecdotal in that people are noticing they're feeling better, they're noticing um, the way that they feel energy wise, inflammation wise, with some of these other health conditions, like we were talking about before, are starting to improve. But overall, I think it's, for the right person, can be a very effective and safe choice. We might be talking about certainly using low doses as implied with microdosing, sometimes looking at other medications. So even liraglutide, the medication I mentioned early on as brand name Saxenda. This is a once a day GLP receptor agonist that is much less potent compared to some of the newer medications, but that can actually be a good thing in the right candidate, in that some of these newer medications are really potent for someone who has a, let's say, 20 or 30 pound weight loss goal. And so that's where I think microdosing can be really effective, in that even the starting doses of, let's say, Zepbound or Wegovy, those are the tirzepatide and semaglutide versions for medical weight loss treatment, that they're going to have very different impacts in someone who has, let's say, 25 pounds of excess weight compared to someone who has 100 or 200 pounds of excess weight on their body. And so choosing a very low dose of medication, choosing a less potent medication, can be very effective with also without sort of overdoing it. And I think that's one of those risks, like we were talking about, from an energy level, from a fatigue standpoint, making sure that we're not suppressing our appetite to the point where we don't want to eat anything. That is absolutely not the goal. So that's where a very low dose can make sense, especially for someone who has a smaller amount of weight to lose or less impacts of metabolic health compared to someone who's maybe been struggling with a more significant amount of weight for a longer period of time.
That's so important and such good information to know about, because everybody talks about microdosing, but what does that actually mean? So thanks for clarifying that.
Yeah, let me add with the microdosing too. I think that sometimes there's this idea that like less is better, like in a morally, like I'm better than you are because I'm taking less medication, or like it's I feel better about myself if I have to take a smaller amount of medication. So what I also want to offer is that there's nothing wrong with taking the amount of medication that your body needs. And so really listening to your body, how you're responding in choosing a dose, and that if you need an FDA approved dose of medication, if you need a higher dose of medication, if that's what your body needs, that's what your body needs, and there's nothing wrong with that. And so sometimes I feel like the microdosing community makes it sound like you should be able to get by with a tiny amount of medication. And while that will be the case for some people, that will not be the case for everybody. And there's nothing wrong with taking more if you need it.
I appreciate you bringing that up and, not shaming anyone, right? Because I think there is sometimes, as with a lot of things, right? As with sexual
Mhm.
health, as with menopause, there's a lot of stigma and taboo around obesity and, what people need to help them get to a healthier weight for their body. And so I appreciate you, mentioning that if you need, the regular, what it's, what it's prescribed as, right?
Mhm.
That's not like a personal failure if you need that. So that's fantastic.
Exactly.
So, what are the most important things for women to understand before starting a GLP-1, including side effects, realistic expectations, and long-term plans?
So I think this is something I could talk about forever.
I
So I
know
don't know how many
you
hours you
have
have, right? But one of the things I think is really important in that, in choosing to start the medication, while certainly I feel very strongly that a patient, they are the boss of their own body. So they get to decide if we're stopping the medication, if we're, titrating up or down on the medication, but recognizing that generally these medications are designed for long-term use. And so in starting the medication, while, like I said, you can absolutely stop them if you want to, you may be surprised with how good your body feels on the medication, with how taking, whichever dose, whether it's a low dose, moderate dose, high dose, whatever your body requires, taking that may really support your goals in a way that it continues to make sense to take it long term. So I do think, for the person who's interested in, like, let me just lose these 10 pounds and stop it, while that may be appropriate for some people, that's rarely going to be the case. Studies show about 10% of people can effectively come off of these medications without seeing significant weight regain. And so, while that will be true for some people, most people will need to continue these medications long term. And so, a take it as you go approach is typically how I recommend it. But being open-minded, at least to the fact that I may be taking this medication, I think is really important. If you have a plan to stop, I hate for someone to set themselves up for a situation where they're just weight cycling. It's just sort of another failed diet where they go on this program, they lose a lot of weight, they stop the program, and then they regain weight. The GLP medications absolutely could be that for somebody if they're not done properly. So, this open mindedness to, I will take the medication for as long as my body needs it, whether that is short term or long term. I think the open mindedness piece there is really important. I also think being an advocate for yourself is really important in that you might be getting prescriptions from a primary care doc, from an obesity medicine doc, from a specialist. We know that a lot of medical spas and online venues are selling these medications as well. And so making sure that you're getting the support that you need, I think is really important. Asking questions, feeling empowered that you can ask questions. If you're being advised to change doses and you're not sure that you need that, to speak up for yourself. So just that permission to speak up for yourself, to be your advocate, I think is really, really important. There's a lot of side effects that can come up with these medications that will be most significant in starting or in titrating the dose. Typically, the side effects that you have early on are the same type of side effects that you might experience later if you're titrating a dose. And when I think about dose titration, I will really look to both effectiveness of the medication in terms of number on the scale, the way it's feeling in your body, and then how side effects are managed when we're thinking about, does this continue to be an appropriate dose of medication versus do you need to increase to a higher dose? And so those will be the tools that I'm really looking at to decide, hey, are we increasing or are we just going to maintain at this for a while? If you are doing well at a dose, I would stay at that dose. There's no reason to continue increasing. Making sure you're staying hydrated, getting adequate protein. We recommend all of our patients take a multivitamin. This will really help too in terms of some of the side effects and helping to manage things like constipation, managing some of the nausea, even things as simple as hydration, protein can really make a difference in some of those things.
What about hair loss? I've recently been hearing a lot of people talk about GLP-1s and hair loss.
Absolutely. So we know that rapid weight loss for any reason can cause hair loss, whether we're thinking about bariatric surgery, GLP medications, a non-medicated journey. And this is all actually a version of telogen effluvium. So the same thing that happens postpartum when you have that luxurious hair during pregnancy. Actually, we don't shed very much hair during pregnancy. Then you have your baby, and 3 to 6 months
All
later, and all of your hair falls
hair
out. The
falls
exact same thing can happen in weight loss. The biggest challenge is it also happens in that, a lot of times, else, not even 3 to 6 months, 4 to 6 months, a lot of times it's not at the beginning of our journey. And by the time it's happening, it's really too late to do much about it. So, starting from the very beginning of your journey with that multivitamin, with good protein support, will be really important. Making sure you're able to adequately nourish your body, those will all help to support. Now, there are people for whom they may experience hair loss despite doing all of those things. And so, if that comes up, just know you are not going to shed your hair forever. Sometimes it feels like it. You're like, oh my gosh, all of my hair has fallen out. I'm not
Mm.
going to have any more left over. You will, it will grow back. But really adequately supporting your body with good fat, with protein, with iron, with your other vitamins will be really important, both just honestly from the beginning, but if you're listening to this and you're like, oh no, I've not been taking a multivitamin and I'm on a GLP, like start today. Starting today is better than nothing. I would be really careful with some of the market for hair replacement vitamins, and it's going to help your hair grow back. Definitely reach out to your physician to talk to them about the best option for that, because there's some that are on the market that can have problems that come up as well. And so you just want to make sure
Mhm.
that you are monitored closely if you are taking those, or that you're making a good choice for what your needs are.
Yeah, absolutely. So, for patients listening who feel stuck, they're gaining weight, losing desire, feeling just not like themselves, what do you think? What would you say to them in terms of their first steps?
I would say ask someone that you trust. Ask a physician who you trust, who you know. Ask them if you are a good candidate for these medications, recognizing that it can be really vulnerable to ask too. And so this, it could be nerve-wracking to do it, but rather than turning to an online clinic or a kind of in and out med spa, really having someone who can walk alongside you in your journey will be important. If you
Yeah.
don't feel like you have a physician that you can trust, I always recommend finding a board certified obesity medicine physician. You can go to the ABOM, the American Board of Obesity Medicine, and they have a physician finder tool. So you can put in your city, you can put in your zip code, you can search for people who are near you who may be able to support. So that can be really good too if you don't feel like there is that physician already in your life. But you really want to go through this journey alongside someone who can support you and who you trust, because this is no different than any other health condition. You wouldn't try to treat your asthma on your own or your blood pressure on your own. You would ask your physician for help. And so I'd really encourage anyone listening to feel confident and comfortable asking a physician for help.
Absolutely, 100%. So, for somebody listening to this podcast who is like, wow, Dr. Stombaugh is so amazing. I just love her. I can't wait to work with her. How can they work with you? Where can they find you?
Absolutely. I try to be available all over the internet. So you can find me on Instagram. I have a podcast called Conquer Your Weight starting in December of 2025. That will also be available on YouTube. So come find me on Apple or Spotify or YouTube. I will be over there. I do have an online course called the GLP Guide. The GLP Guide is an online on demand video program for patients who are taking GLP medications who feel like they need a little bit more support and aren't getting that, or it's like, it's midnight and you're trying to like Google some questions. I want to be that resource for people. And so we address all sorts of things. How do you travel with medications? How do you inject the medications? How do you manage each of the side effects? How do you get insurance coverage? What do the cost of medications look like? What do you say when someone talks to you about, oh my gosh, you've lost a lot of weight. What have you done? We address all of the most frequently asked questions that come up. And so that is a phenomenal resource. You can find that on my webpage at sarahstombaughmd.com/GLP. I do see patients in person in Charlottesville, Virginia, and by telemedicine throughout the states of Illinois, Tennessee, and Virginia for any of your listeners who are located in those states.
Amazing. You are so filled with so much knowledge that I think anyone that works with you would be super lucky. So, thank you so much for coming on, Dr. Stombaugh. This was such an enlightening conversation, and I'm so glad you were able to make time out of your schedule to come on. And well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical information, or medical advice. It is meant to be medical information, just not advice. So if you have any questions about your health, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.